Welcome to the deep dive. Today we are putting on our surgical lenses and diving deep into, well, the absolute core of foot and ankle pathology, instability.
Exactly.
Our challenge is to navigate the treacherous waters from that simple-looking inversion sprain that just won't heal, all the way to complex intra-articular lesions.
Right.
The stuff that determines whether you spend all night studying Campbell's or not.
Exactly. We are essentially creating the definitive cheat sheet for managing the unstable ankle. Our mission, understand the decision tree.
Yeah. How do you distinguish an acute, clean, ligamentous tear that responds to primary repair from the chronic, long-standing instability that demands, a full reconstruction using specialized grafts or advanced cartilage technique?
That's the key. If you're preparing for a complex case or just want to master the nuance of lateral ankle surgery, this is your ultimate preparation review.
We're setting the tone like we're reviewing the operative plan together, right before scrubbing in for a big morning list. We'll cover the gold standards, the historical heavy hitters, and the critical pitfalls you must avoid. Okay, let's start where most cases begin. The acute rupture of the lateral ligament complex. This means damage primarily to the anterior talofibular ligament, ATFL.
Yep, ATF.
Often combined with injury to the calcaneofibular ligament, CFL.
Right. And the standard bearer, the procedure that has proven its worth time and time again for anatomical repair, is the Brostrom procedure.
Almost always performed today with the Gould modification, though.
Absolutely. It's the bedrock of lateral ankle surgery. But before we even touch the ligament, we have to talk about the surgical map, the approach.
Right, the incision.
Yeah, the source material outlines a really precise approach. It helps minimize morbidity, maximize exposure. It's a curved line starting about 5 centimeters proximal to the distal tip of the fibula, then curving distally and posteriorly, ending approximately halfway between the fibular tip and the heel tip. You'll see it in figure 90.2.
That curved approach is key, isn't it? It lets us manage the soft tissue without creating excessive tension.
Exactly. But the moment you start that dissection, you are walking a tightrope.
And the tripwires are those sensory nerves.
That's the most critical warning,
Well,
You must identify and preserve 2 main nerve groups.
okay.
Anteriorly, you've got the superficial peroneal nerve branches. They often lie dangerously close to the talar end of the injured ATFL.
Right near the target.
Right. And posteriorly, the sural nerve is draped right over the peroneal tendons. As we know, even a technically perfect ligament repair can be deemed a failure if the patient's left with persistent nerve pain.
Oh, absolutely. Dysesthesia. It's awful.
Awful. You have to handle them so delicately. It's like avoiding tripwires in a darkened operating room.
Good analogy. Okay, so once we've navigated the nerves, we identify the ligaments. The ATFL often appears as, not much more than thickened, attenuated tissue in the anterior capsule, right?
Yeah, sometimes it's really flimsy.
Ooh.
And the CFL is deeper, running beneath the tip of the fibula and deep to the peroneal tendons. This is where the case can immediately get difficult.
Okay. Why is that?
Well, it's easier when the ligaments have torn mid-substance or maybe peeled cleanly off the fibula. The technical difficulty skyrockets when the CFL has avulsed from the calcaneus rather than the fibula.
Right, because you can't just sew it back end to end.
Exactly. You can't just reapproximate it. You have to anchor it directly back to the calcaneus, often requiring small suture anchors or drilling tunnels for secure fixation. Figures 90.20b and c sort of illustrate this conceptually.
Okay. But the beauty of the Brostrom itself, the core idea, is its simplicity. It's about shortening and reattaching native tissue.
Right.
We use non-absorbable suture material to approximate the torn ends. But why is the Gould modification such a kind of non-negotiable step now?
Because it's the structural insurance policy. It really is.
Yeah.
After the primary anatomical repair is completed, so ATFL and CFL are reattached, the Gould modification mandates that we use the proximal lateral edge of the inferior extensor retinaculum.
Okay.
We suture this layer over the repaired capsule and ligaments. It provides this robust, non-anatomical reinforcement that prevents early stretch or failure.
So it adds that extra layer of stability.
Yeah.
Figure 90.20D shows that pretty clearly.
Vividly, yeah.
And for our high-demand patients, like athletes or, those with generalized ligamentous laxity, we're seeing the rise of suture augmentation, these non-absorbable suture tapes.
The internal brace concept.
Exactly, secured to the talus and the fibula using anchors.
It's a bit of a game changer for immediate stability, I think. When placing these anchors, figures 90.20E and F are crucial. You have to get the placement right.
Where exactly?
The anchors need to be proximally on the talon neck, directed slightly superiorly and posteriorly. That trajectory ensures the tape mimics the anatomical path of the ATFL.
So it supports the repair immediately while the biology, the actual healing, takes place underneath.
Precisely.
Okay, so we have a successful operative repair. Fantastic. But we know surgery is only, what, 50% of the game?
At best, sometimes.
What's the single most critical instruction in the post-operative protocol to prevent immediate failure, that one thing you hammer home?
Oh, that instruction is absolutely non-negotiable. It really separates the successful repairs from the failures. The ankle is initially immobilized in mild eversion.
Right.
At 2 weeks, we transition to a walking boot, touchdown weight bearing, start some gentle active motion. However, the cardinal rule, emphasized everywhere, is that inversion past neutral is not allowed until 8 weeks after surgery.
8 weeks. Wow. Why that specific timeline? Why is that initial phase so critically vulnerable to inversion stress?
It's all biology.
Yeah.
That initial 6 to 8 weeks is when the healing tissue, the surgically repaired ligament, is maturing. It's undergoing cellular remodeling. If you apply inversion stress too early, you risk lengthening or just tearing the repair. You basically turn an acute repair into a chronic failure.
Undoing all your work.
Exactly. By 8 weeks, the tissue has sufficient structural integrity to begin formal strengthening and, controlled functional rehab before progressing to full weight bearing. You just have to respect the biology of ligament healing.
Okay, moving on from the acute scenario. Let's talk about the patient who presents months, maybe even years after the initial injury, complaining their ankle still feels loose or gives way.
The chronic instability patient.
Yeah, we're now dealing with chronic instability, and the decision shifts, right? From simple repair to potentially complex reconstruction.
First, we always emphasize the conservative pathway. Chronic instability, if it's symptomatic, must first be treated non-operatively.
Makes sense. What does that involve?
Simple things, often. Broadening shoe heels, maybe using lateral wedges, high-top shoes, or, and this is probably most effective, semi-rigid ankle orthosis.
Like an ASO brace or something similar.
Exactly. The evidence clearly shows that these semi-rigid braces provide better initial protection than just simple athletic taping.
Okay. So, when do we finally abandon the conservative path and schedule the OR? What are the triggers?
Well, it's when the patient exhibits severe functional disability, when they have failed a structured, dedicated muscle-strengthening and proprioceptive program, and when they continue to suffer recurrent sprains. We intervene because, honestly, every subsequent sprain increases the risk of associated injuries.
Like damage to the joint surface.
Particularly damage to the joint surface, like those osteochondral lesions of the talus, OLTs. And that's a much bigger problem than just a torn ligament.
Right. So, to make that surgical decision, we need objective criteria. We have to distinguish between mechanical instability and functional instability. How do we objectively define mechanical failure?
Mechanical instability is quantified. We rely on stress radiographs. The definitive criterion for surgical intervention is showing 8 to 10 degrees of increased talar tilt compared with the patient's uninjured ankle. That comparison is key.
Got it.
That radiographic difference, which you can see clearly in figure 90.23a, confirms true ligamentous laxity. If that increased talar tilt is absent,
Then the ligaments are probably okay structurally.
pretty much. If the tilt isn't there, we know the ligaments are structurally sound, and we absolutely must seek other causes for the patient's symptoms.
And if those stress radiographs are negative, what's the next step in our investigative pathway? Where do we look?
If the anatomy looks sound on stress views, the problem is likely functional instability. This is that subjective feeling of instability, the ankle giving way,
Right.
which is often rooted in neuromuscular or proprioceptive deficits. It means the physical hardware, the ligaments are fine, but the software.
The body's ability to sense and react?
Exactly. The software is lagging. However, a negative stress exam also forces us to hunt for other occult derangements. Things like a subtle stress fracture, which might only be visible on a dedicated bone scan, like figure 90.21 illustrates.
Okay. Now let's talk about those associated lesions we might find, particularly in patients with chronic pain after an inversion injury. You mentioned the excrescent lesion. What is that?
Yes. The excrescent lesion is a fascinating bony adaptation, really. It's a symptomatic anterolateral exostosis, basically a bone spur that forms right where the ATFL attaches. It can be a significant source of chronic pain, and It might only be fully appreciated on a CT scan.
So if we're doing a Brostrom for instability in these cases.
Then surgical excision of that bony spur combined with the ligament repair is often necessary to achieve full pain resolution. You have to address both.
Okay, this brings up a common operative debate. Should we routinely perform an arthroscopic examination before or maybe during the open ligament reconstruction?
Yeah, that's a hot topic.
Because if we skip the scope, aren't we potentially missing too many occult cartilage problems like those OLTs we just talked about?
That is the core of the dilemma, and honestly, there are strong arguments on both sides.
Okay.
On one hand, many experts absolutely recommend arthroscopy to rule out or treat a chondral lesion that would otherwise compromise the long-term result. You don't want to miss that.
Makes sense. What's the counter-argument?
The counter-argument is very real for the open surgeon. Performing arthroscopy first requires massive fluid extravasation into the lateral soft tissues.
Right, the tissue gets all boggy.
Exactly. And that fluid makes the subsequent open procedure identifying the tissue planes for the ligament repair significantly more difficult. And it increases the risk of damaging those crucial sensory nerves we discussed earlier.
Ah, okay. So it's a trade-off.
It's a definite trade-off, risking a slightly messier open repair versus potentially missing a treatable cartilage lesion. There's no single right answer for every case.
All right, let's assume we've decided the laxity is too severe, or maybe the patient has failed a primary repair, or they have generalized hypermobility. Simple native tissue repair isn't going to cut it.
Right, we need more firepower.
We need serious structural reinforcement. Traditionally, that meant augmentation or reconstruction using a tendon graft, usually half or maybe a third of the peroneus brevis. This is where we pay homage to surgical history, the era of the heavy hitters, the tendon transfers.
Yes. If you're going to be an orthopedic surgeon, you absolutely must know these names. Watson-Jones, Evans, and the Christman-Snook modification of the Elmsley procedure.
All three procedures using the peroneus brevis tendon.
Correct. Which provides dynamic stability, but it's structurally sacrificed for static ankle stability in these procedures.
Okay, let's start with the Watson-Jones technique 90.3. What was its goal, and maybe why did it fall out of favor a bit?
The goal of Watson-Jones was ambitious, to reconstruct both the CFL and the ATFL anatomically, or at least attempt to. It uses the peroneus brevis tendon, winding it through 2 tunnels in the fibula and 1 in the neck of the talus. It aimed to provide comprehensive anteroposterior and talar tilt stability.
And the results?
Pretty good, actually. Excellent or good results reported in up to 93% of patients. It was particularly effective at reducing that anteroposterior instability.
So if the results were that good, why did surgeons start looking for alternatives? What were the downsides?
Technical difficulty and donor site morbidity, mainly. Drilling that tunnel in the neck of the talus. Well, it's incredibly challenging to execute precisely, especially without damaging the articular cartilage right above it.
Oh yeah, I can imagine.
Furthermore, the length of the harvested peroneus brevis tendon strip may simply be too short to span all 3 tunnels and maintain the right tension. If the tendon strip is too short, the procedure is basically compromised from the start.
Okay, that leads directly to the Evans procedure then, technique 90.4, which was designed to simplify the technical steps, right?
Exactly. The Evans procedure is much cleaner, surgically speaking. It overcomes the difficulty of the talar tunnel by just eliminating it entirely.
So what does it reconstruct?
It primarily reconstructs the CFL. You harvest the anterior half of the peroneus brevis tendon, pass it through a single tunnel drilled through the fibula from inferior to superior.
Okay, like in figure 90.27b.
Precisely. And then you suture it back onto itself or the surrounding periosteum. It's excellent at controlling talar tilt, and it has strong success rates.
But the Evans procedure carries a significant long-term consequence, doesn't it?
Yeah.
A known issue.
Absolutely. The main problem with the Evans is that by routing the peroneus brevis, which is an everoder,
Right.
by routing it directly through the fibula, you permanently change the foot's kinematics.
That's so.
Studies show that while it restores mechanical stability, patients often experience altered foot function, and critically, a significant loss of eversion strength.
Ah, that makes sense.
Yeah, and this kinematic change over decades can contribute to secondary problems, including early arthrosis. Because of this permanent alteration and potential stiffness, it's now heavily recommended that Evans only be used when an anatomical Brostrom repair is genuinely impossible.
Okay. So, given the stability success, but the kinematic cost of the Evans, surgeons developed a compromise. The Christman-Snook modification of the Elmsley procedure, technique 90.5. How does this procedure try to fix the problems of its predecessors?
Well, Crispin Snook tries to achieve the stability of the Watson-Jones, but with a better functional outcome, hopefully, than the Evans. It's arguably the most anatomically oriented of these tendon transfers.
How does it work?
You split the peroneus brevis longitudinally from its insertion all the way up to the muscular tendinous junction, creating two long, robust strips of tendon.
Okay. And the path of those strips is the defining characteristic, right?
Precisely. The graft path is complex but highly purposeful. One strip passes through the fibula and is secured, effectively replacing the ATFL.
Got it. And the other?
The other strip passes through a separate tunnel drilled through the calcaneus, replicating the postero-inferior course of the original CFL.
So it hits both ligaments.
By stabilizing both the ankle and the subtalar joint with separate strips, it provides really comprehensive stability. When securing the graft in the calcaneus, the foot must be held in mild ersion, not forced eversion, to ensure proper tension without causing excessive stiffness later on.
And biomechanically, the Crispin Snook showed great promise.
Yes, it did. Cadaver studies were quite clear. Of the three major transfers, only the Crispin Snook resulted in an ankle joint complex that was significantly more stable than the surgically cut state. It was the stability champion, you could say.
There's always a but.
There's always a but. Those same studies highlighted the trade-off. The Crispin Snook resulted in ankles with significantly less motion than intact ankles.
Stiffness again.
Stiffness again. You exchange some dynamic freedom for static stability. It really locks the ankle down.
Okay. This inherent stiffness, combined with the technical complexity and the donor site morbidity, that explains why the surgical pendulum has swung pretty dramatically back towards anatomical repair, doesn't it?
Absolutely. Our current source material confirms it. The modified Brostrom technique remains the treatment of choice for moderate or severe instability. It just offers comparable stability results to the transfers.
But with fewer downsides.
Exactly. Significantly fewer long-term complications, less stiffness, and superior functional outcomes because it preserves the native anatomy and, crucially, the peroneus brevis tendon.
So where do the tendon transfers fit into modern practice? Are they just, historical artifacts we learn about for exams?
They are not historical artifacts, but they are definitely reserved for highly specific, high-risk cases. We use tendon augmentation, like shown in figure 90.26. Either a Brostrom augmented with a portion of the peroneus brevis or maybe a full Crispin Snook, really, as a salvage procedure.
Salvage only. For who?
This is strictly for patients with severe generalized hypermobility, maybe a long-standing chronic insufficiency where the native tissue is just poor, high BMI, they mention over 240 pounds, or patients who have already failed an initial Brostrom repair.
Okay.
These are the cases where native tissue simply cannot provide adequate structural strength on its own.
We should briefly touch on medial instability, the deltoid dilemma. Why is this structurally more forgiving sometimes, but surgically less rewarding?
Yeah, medial instability is less common and often less functionally debilitating, mainly because the fibula provides such robust lateral restraint. The bony anatomy helps.
Okay.
However, when it does become chronically incompetent, the results are dangerous. The talus shifts into a valgus tilt.
Then that leads to...
That irrevocably leads to wear and tear, or tibiatellar arthrosis. Unfortunately, reconstruction of a chronic deltoid tear is simply less satisfactory than lateral repair. It's often due to the difficulty in accessing the deep layers of the deltoid and the high tension required for a meaningful repair. It's just a tougher problem surgically.
Okay, let's pivot to the diagnostic nightmare scenario. You have a patient with chronic lateral ankle pain, yet your stress tests are negative for mechanical laxity.
Right, the ligaments feel solid.
The ligaments are holding, but the patient is miserable. We now have to broaden our differential diagnosis to these occult derangements.
We turn into anatomical detectives at this point. We're looking for things like tarsal coalition, maybe subtle stress fractures we missed, or the various impingement syndromes. Our first stop is often the poorly understood but commonly diagnosed sinus tarsi syndrome.
The classic junk drawer diagnosis of the ankle.
Chuckles. That's a perfect analogy, actually.
We look there when everything else seems clean and tidy.
It fits. Sinus tarsi syndrome, first described way back in 1958, is basically persistent pain localized specifically in the sinus tarsi after an ankle sprain. It's vaguely defined, often linked to subtalar instability, or maybe just simple soft tissue changes like scarring or fat atrophy within the sinus itself.
Okay, so how do we confirm this diagnosis before we even think about intervention? How do we nail it down?
The diagnostic criterion is simple and critical: an injection. If the injection of an anesthetic agent combined with cortisone provides at least temporary and ideally permanent relief,
Then that's likely the source.
then the diagnosis is confirmed. That injection is both diagnostic and often therapeutic. If surgery is required, it generally involves debridement of the soft tissues within the sinus, taking absolute care to preserve the underlying interosseous and cervical ligaments that stabilize the subtalar joint. You don't want to cause instability yourself.
Right. And sometimes that jump drawer hides something truly unexpected, doesn't it? A real curveball.
Yes, the source materials highlight this zebra finding. 3 patients who initially presented with classic sinus tarsi syndrome symptoms were later found to have a discrete osteoblastic lesion, a benign bony tumor in the calcaneus.
Wow.
It required excision for complete resolution of their pain. So you always have to maintain a high level of suspicion for the unexpected, even with the common diagnosis.
Good point. Let's move to the bony culprits then, specifically anterior impingement syndrome. This is classically the athlete's problem, right?
Indeed. It was highlighted by O'Donoghue back in the late 50s. Anterior impingement is characterized by chronic aching that worsens significantly with forced dorsiflexion.
Like squatting or climbing stairs.
Exactly. It's caused by repetitive trauma, often seen in dancers, basketball players, soccer players. It leads to the formation of osteochondral ridges, or exostoses.
Bone spurs.
Bone spurs, yeah, on the distal tibia and the opposing dorsal neck of the talus. It's like having a little rock stuck in the hinge of the joint, basically.
We use the Scranton and McDermott classification to grade these spurs. Grades thirst for figure 90.35.
Okay.
How does the grade inform our decision making?
The grade directly correlates with the severity of the pathology and critically the anticipated recovery time.
Okay.
Grades the first and 2 are minor spurs, maybe manageable conservatively sometimes, while grades the 3rd and 4 represent larger, established exostoses that usually require surgical intervention.
And the goal of treatment?
Complete surgical excision, typically performed arthroscopically using the technique popularized by Ogilvy Harris, technique 90.6.
Okay. Talk us through the technical key to that arthroscopic resection. What's the tricky part?
We use standard anteromedial and anterolateral portals. The absolute technical trap, again, is the superficial peroneal nerve near that anterolateral portal.
Always the nerve.
Always the nerve. You must protect it meticulously. We use usually a 3mm burr to remove the spurs, but the surgical endpoint is vital. You must resect the spurs back to the level of normal cartilage and subchondral bone.
Don't leave anything behind.
Exactly. If you leave even a small ridge, the symptoms will likely recur. You have to be thorough.
And there's a sneaky soft tissue structure that often acts as the hidden culprit in impingement, isn't there? Bassett's ligament.
Yes, Bassett's ligament. It's the anatomical nuance that many can miss. It is simply the distal fascicle of the anterior inferior tibiofibular ligament. It's present in most ankles, but this discrete fascicle can become thickened or scarred after an injury, and then it causes direct impingement and abrasion of the talar cartilage during dorsiflexion. Figure 90.36 depicts this quite clearly.
So if we've adequately removed the bony spur, but the patient still has that impingement pain, especially with dorsiflexion, we should specifically look for that hypertrophic fascicle.
Exactly. If the Bassett's ligament is thickened and causing abrasion, simply resecting that hypertrophic tissue arthroscopically, in addition to the bony spur removal, is often the final step needed to entirely alleviate the impingement pain. It can be the key.
Okay, let's transition now to probably the most serious intra-articular pathology we've mentioned, osteochondral lesions of the talus, OLTs, or transchondral fractures.
The cartilage crisis, indeed.
Over 85% of these injuries are caused by trauma, usually a severe inversion sprain, and they are tragically easy to miss initially, aren't they? Often misdiagnosed simply as a persistent sprain in the ER.
Absolutely. OLTs represent a crisis because they compromise the articular surface, the actual smoothness of the joint. Our diagnostic foundation relies heavily on the Burton-Hardy classification from 1959. Figure 90.39 shows it well.
Right, the 4 stages.
Yeah, it divides the injury into 4 stages based on radiographs. Stage 1 is simple subchondral bone compression. Stage 2 is a partially detached fragment. Stage 3 is detached but still sitting in its bed undisplaced. And stage 4 is the bad one, completely detached and displaced, floating in the joint.
Okay. Beyond staging, location matters immensely, doesn't it? Lateral lesions and medial lesions have different presentations, different mechanisms, and require different surgical approaches. What are the key morphological differences?
It's highly consistent, actually. Medial lesions are far more common. They're typically situated more posterior on the talar dome. They tend to be deeper, more cup-shaped, and usually remain non-displaced.
And the mechanism for medial?
They result from an injury mechanism involving inversion, plantar flexion, and some lateral rotation of the tibia on the foot.
Okay. And the lateral lesions, how are they different?
Lateral lesions are generally located more anteriorly on the talar dome. They tend to be shallower, wafer-like, and are far more likely to be displaced.
Mechanism there.
They occur from an inversion mechanism combined with strong dorsiflexion, basically crushing the cartilage against the opposing tibial plafond.
Imaging is key here. We need high-resolution CT scans, right? Like 2 mm cuts.
Yes, CT is crucial to precisely measure the location and the size of the bony defect. But MRI provides that crucial detail for the soft tissue, the cartilage itself.
How so?
Well, MRI is essential for identifying those subtle stage eye lesions, the bone bruises. And it's great for evaluating the integrity of the overlying cartilage cap and checking for fluid around the fragments, which suggests instability.
But the most definitive classification systems are arthroscopic.
Ultimately, yes. Systems like those from Prish or Cheng,
Right.
outlined in Table 90.1, are based on direct inspection and probing of the cartilage during arthroscopy. You can determine if it is smooth but soft, frayed, fissured, or completely unstable.
Okay, regarding treatment philosophy, which lesions mandate early surgery, and which ones can we maybe try to manage conservatively first?
Most acute, stable lesions, stages I and II, usually start with conservative management, non-weight-bearing immobilization for a period.
Right.
However, displaced stage 4 lesions, the floaters, and acute, completely detached lateral lesions, stage 3, even if undisplaced initially, should probably move immediately to surgery.
Why the urgency there?
Due to the high risk of non-union and the rapid onset of early arthritis if that fragment doesn't heal back properly or gets lost.
Okay. For our first line of operative management, typically for the smaller lesions, we rely on debridement and stimulation techniques.
Yes, this involves curettage of the defect crater, getting down to good bleeding bone, and then stimulating that subchondral bone to promote vascularization, the superquad approach, we sometimes call it.
Using techniques like microfracture or drilling.
Exactly. Microfracture or drilling. For medial lesions, which are often posterior and difficult to access anteriorly, we often prefer percutaneous arthroscopic drilling using a retrograde approach, going through the sinus tarsi.
Why retrograde?
It's technically challenging, no doubt, but it's crucial because it preserves the intact articular cartilage on the talar dome.
Yeah.
You're drilling up from underneath.
Ah, clever. But exposure is the true nightmare, isn't it? Particularly for large or posteromedial lesions. You mentioned lateral lesions are easier.
Yeah, lateral lesions are generally easier to manage because the lateral malleolus sits slightly posterior, giving us better anterior access to the talar shoulder. But for medial lesions, especially large or posterior ones, sometimes we simply can't avoid a controlled break of the bone.
An osteotomy.
Correct. For superior visualization of large or deeply situated medial or posteromedial lesions, we often have to resort to the chevron-type medial malleolar osteotomy, technique 90.7, described by Cohen et al.
This is a highly technical maneuver. The precision required here seems absolute. Talk us through the technical traps of doing that osteotomy safely.
Okay, the cut itself is a chevron shape with the apex pointed proximally. The absolute key is the angle of that cut. It must be directed precisely toward the junction of the medial malleolus and the tibial plafond articular surface. Figure 90.52 shows this angle.
What happens if you get the angle wrong?
If you angle the cut too obliquely, too flat, you risk entering the weight-bearing surface of the tibia itself. That creates a massive secondary problem, an articular step-off.
Right.
If you angle it too vertically, you severely limit your visualization of the lesion, defeating the purpose. A well-placed chevron gives you that superior access while protecting the posterior tibial tendon, which runs right by your surgical field.
Yeah.
You have to be careful with that, too.
Makes sense. Though the osteotomy is sometimes unavoidable, surgeons are always trying to find ways around it, aren't they? We see alternatives like Flick and Gold's technique of grooving the distal tibia, figure 90.46 shows that, to try and get better access to that posteromedial corner without breaking the bone.
Those are clever tricks, for sure. But for large, deep lesions, especially those stage 4 ones with significant bone loss, we often move beyond simple stimulation to full reconstruction of the defect.
Right. This means the osteochondral allograft transplantation system, OATS procedure, or mosaicplasty. technique, 90.1.
Exactly. This is generally reserved for larger defects, typically defined as greater than 5 millimeters in diameter, sometimes larger depending on the surgeon.
The analogy I use for mosaicplasty is like retiling a chipped bathroom floor, but with living tissue.
Chuckles, that's a good one. You are harvesting perfectly sized cylindrical osteochondral plugs, ranging maybe from 5 to 11 millimeters in diameter from a non-weight-bearing area.
Usually the knee, right?
Usually the ipsilateral knee's medial or lateral femoral condyle. Sometimes allograft is used too.
And it's extremely technically demanding.
Oh, absolutely. You're inserting multiple plugs into the callar defect to try and recreate that smooth, convex articular surface. The real technical challenge is achieving a perfectly smooth surface at the end.
What's the key there?
The plugs must be inserted either perfectly flush with the surrounding cartilage or, ideally, slightly recessed, maybe half a millimeter down.
Why recessed?
If the plugs are even slightly elevated, proud, they create a pressure point that guarantees pain and premature wear of the opposing tibial cartilage. Mismatching the curvature or leaving significant gaps between the plugs is also a recipe for failure. It has to be meticulous.
And for really massive lesions, say greater than 12 millimeters, the options become even more specialized, don't they?
Yes. Then we start shifting towards using fresh talar allografts, like a mega-OTs, or perhaps the cutting edge, autologous chondrocyte transplantation, MACI.
Explain MACI briefly.
It involves harvesting the patient's own cartilage cells, sending them to a lab to be cultured and expanded, and then placing them back into the defect, usually contained within a biologic matrix or scaffold. MCI shows tremendous promise for those really large defects, where harvesting a sufficient number of plugs from the knee would be too risky or cause too much donor site morbidity.
Okay, to try and summarize the massive amount of detail we've covered, we can refine our decision tree for managing the unstable ankle.
Let's try. So, acute ligamentous instability, generally treated with primary anatomical repair, the modified Brostrom Gold.
Right. With that critical, non-negotiable post-operative restriction,
Right.
no inversion past neutral for 8 weeks. Gotta let that biology work.
Absolutely. Then chronic instability requires a solid trial of conservative management first.
Bracing PT.
Exactly. If that fails, our primary surgical preference is still the modified Brostrom technique, perhaps augmented with suture tape if the patient is a high-demand athlete or has questionable tissue.
Okay. And we reserve the classic tendon transfers, the Evans, Watson-Jones, or Christman-Snook.
Strictly for true salvage situations. Patients with extreme hypermobility, maybe failed primary repairs, or significant obesity. And we have to understand that we trade some motion for that static stability when we use them.
Got it. If the patient has chronic pain but no mechanical laxity on exam or stress x-rays.
Then we aggressively investigate the occult derangements, sinus tarsi syndrome, confirmed by that diagnostic injection, or anterior impingement.
Requiring arthroscopic excision of bony spurs or maybe that pesky hypertrophic Bassett's ligament.
Right, and remember that the cartilage crisis, the OLTs, demands precise classification and really careful planning.
Medial lesions, often posterior, may require that difficult chevron-type medial malleolar osteotomy for visualization.
And for large defects, we escalate to reconstruction using mosaicplasty or OATS, or maybe even MACI for the really big ones.
A vital piece of operative wisdom, I think, that every learner must grasp, especially given how tight the ankle joint can be. A well-done arthrotomy is always superior to a poorly done arthroscopy.
Couldn't agree more. If you cannot get the visualization or the space required to execute the repair or the removal perfectly through the scope, open it up. Don't compromise the outcome just trying to force a minimally invasive approach when it's not appropriate.
Good advice. And finally, you noted the evolution in post-op philosophy.
Yes. While long immobilization was traditional for decades, studies, like those by Carlson et al., are now guiding us toward early mobilization protocols after lateral ankle reconstruction.
So getting the moving femur?
Allowing controlled, earlier motion seems to lead to an earlier return of functional plantar flexion strength compared to the classic 6 weeks of cast immobilization, and importantly, without compromising the stability achieved during surgery. It's a shift towards function.
Okay. And that wealth of knowledge leads us nicely to our final provocative thought for you, the listener, to consider as you digest all this material. We see this rising trend of using synthetic augmentation, that suture tape internal brace, to reinforce the modified Brostrom. It essentially replaces the static structural role previously performed by tendon transfers in many cases.
So the question becomes, given that high-tech internal bracing is now readily available and quite effective, Does this mean the classic complex peroneus brevis tendon reconstruction procedures, the Watson-Jones, the Evans, the Crispin-Snook, are now truly destined to become purely historical artifacts, things we just read about?
Or do they still hold a vital, specialized role strictly as a salvage option for that patient with true, severe, generalized hypermobility that maybe no amount of synthetic tape can adequately contain?
It really raises the fundamental question. Are we simply perfecting the treatment of the symptom of instability with these newer techniques? Or are we potentially sacrificing the patient's long-term biomechanics forever when we harvest and reroute that native tendon in the older procedures? Something to think about.